Welcome to this CTSNet original webinar, a multidisciplinary approach treating complex endometriosis. Thank you for joining us. Please note this webinar is being recorded and will be available early next week on ctsnet.org and CTSNet's YouTube channel. At this time, I'm pleased to introduce the moderator for this webinar, Dr. Leanne Ashrafian. Dr. Ashrafian, CTSNet's Thoracic Senior Editor, is a consultant thoracic surgeon in the Department of Thoracic Surgery at Guy's Hospital in London. Thank you for joining us, Dr. Ashrafian. We'll turn the panel over to you.
Thank you very much, John. So welcome everybody to this CTSNet webinar on a multidisciplinary approach to treating complex endometriosis. I am very pleased to be joined by our esteemed panel. With me I have Mr. Shaheen Khazali, who is an award-winning consultant gynecologist specializing in complex robotic and laparoscopic surgery with a specialist interest in endometriosis. I also have with me Mr. Rajesh Nair, who is a consultant urological surgeon based at Guy's and St Thomas's, again with a specialist interest in minimal access surgery and complex uro-oncology. And thirdly, I have with me my colleague, Mr. Bille, who's a consultant thoracic surgeon at Guy's and St Thomas's, and also has a specialist interest in the treatment of complex endometriosis from a cardiothoracic perspective. So thank you, everybody, for joining me. We're very excited to have you here and to talk through this complex condition. I'm going to start by handing over to Dr. Khazali, who's going to talk to us about endometriosis as a condition and take us through some of the interesting cases that we'll then go on to discuss in more detail. Thank you.
Thank you very much, Leanne, and thanks for inviting me. I was just saying before we came on that this is the second time that I'm speaking to a group of thoracic surgeons, proper surgeons, you may want to call them. So I'm very pleased to be here. I'm going to share my screen. So, yes, endometriosis. I work in London. I'm mainly at the Lister Hospital in Chelsea, and my interest is endometriosis. Almost all of my workload is advanced endometriosis. I have no conflict of interest related to this topic. So what I'm going to do today is just to go through the principles of endometriosis surgery, what it is, what we do, how do we form an MDT, and how do we work together. And then I will share a few cases of thoracic endometriosis, and we'll touch on what we do at CMIG London. So what is endometriosis? Apologies if you already know this, but we're dealing with, you can almost say, the other end of the body. So maybe as thoracic surgeons, you don't necessarily come across endometriosis very often. So when the endometrial tissue or tissue similar to the lining of the womb grows outside the uterus, we call it endometriosis. That causes inflammation, fibrosis, adhesions, and it can become quite problematic. So we can have this growing in all sorts of places, in the ovaries, in the bowel, in the ureters, in the bladder, and in the chest. So the extrapelvic endometriosis, in fact, the most common place for extrapelvic endometriosis is the chest. And that's why for my work, working in an MDT is priceless. Actually, you can't do this without having a proper MDT. So my work is some surgery, but some important part of my work is building teams and finding the best of the best and bring them together and work with them for these complex cases. So this is an example of rectovaginal endometriosis, and that's when I need a colorectal surgeon to remove part of the bowel or do a disc excision, which I will show in a bit. What are the symptoms? Pain is the big one, painful urination, dyspareunia, painful sex, pain on opening your bowels. And when it comes to thoracic endometriosis, the main symptoms would be chest pain, shoulder tip pain, and cyclical pneumothorax or cyclical hemothorax, and more of that later. So basically, the patients feel a bit like that. And I feel very strongly about this part because, you know, this is a condition that for many years has been ignored. It takes around 8 years in this country to reach a diagnosis. And it has been seen by many as a, if you like, lifestyle condition, but it is far from that. It wrecks lives and it affects the lives of women in a very unfair way. What I mean by that is that right at the time that a young woman wants to start a family or start a business or sort out their education, they have to deal with this. So yeah, 7.5 years for diagnosis. It's very common. It's much more common than most people think. It's as common as diabetes in women. So you have roughly the same number of women with diabetes in that age gap, age range between around 19 and 45, as you have endometriosis patients. It costs the society a lot, but we won't go into the details of that. Fortunately, there's been a lot of attention more recently in the media and social media, and therefore you are likely, as surgeons of any specialty, you are likely to come across it a lot more. So these are two of the recent ones, both my patients who have sort of been helping raising awareness. I started helping in this a few years ago when BBC approached me and they said I have a face for the radio. So they wanted me to do a radio interview, and then that continued with Kate Garraway on Your Body Uncovered, where they said, okay, maybe if you cover part of your face, we'll let you do a TV program as well. So this was a very interesting program where we use augmented reality to look inside the body and, you know, walk around the anatomy, show the patient what it is that we're dealing with. These are endometriomas, and this is this patient's uterus and the adenomyosis and the rectal nodule that she had. So what's the problem? Let's forget about how we manage it and the medical management and, you know, all the rest of it. Let's focus on surgery. The problem with the surgical management of endometriosis and the challenge is the fact that to remove the disease, to excise the disease, you need to work around structures that may not necessarily be familiar to a general gynecologist. So you need to be familiar with the retroperitoneal anatomy, and endometriosis is like an iceberg. So you really need to excise it completely. And by excising, I mean you need to go so deep that you get below the abnormality. And that sometimes means getting into the tiger territory in the pelvis. And that's why working in the multidisciplinary team really is the key. And I really believe that this is what everybody should be striving to. You know, just saying that I can do it myself and therefore I will do it myself is only going to go so far. So our MDT consists of colorectal surgeons, a specialist nurse for endometriosis, pain specialists, fertility specialists, thoracic surgeons, and urologists, transplant surgeons, and a neurosurgeon that sometimes helps us as well. And we have regular MDT meetings that we discuss the difficult cases. And I have to say, Andrea has been a very regular attender and is always there to help with the thoracic cases. So the British Society of Gynae Endoscopy is actually a very successful organization in centralization of endometriosis care in this country. So UK is really ahead of many other countries in that respect, that around 25 years ago, in fact more, 28 years ago, they established a centralized system for endometriosis centers. And it publishes the number of difficult cases that they deal with on a yearly basis. And I've just put this very humble arrow to show where our center is. But it is a really good project that makes sure that complex cases are managed inside a multidisciplinary team. So we look at the complications of our surgery, obviously. We look at the complexity, which goes up and up and up. That just is a good way to make sure that these complex cases have the right sort of clinical governance structure, are managed within a right clinical governance structure. So what does the surgery look like? So this is a bowel endometriosis. This is a nodule that has grown inside the bowel, and I'm working with the colorectal surgeon to remove that through a transanal discoid excision. And you will notice that we've done bilateral ureterolysis, and we have excised all of the abnormalities within the pelvis. And my particular interest is also nerve endometriosis. This is another case that I think Raj was there when we did it together, actually. The endometriosis has invaded into the nerves of the pelvis, and that would require us to go really in deep, dark areas. This is the sciatic nerve and chocolate material coming out of the sciatic nerve. So we need to do a neurolysis to get to the sacral nerve roots to be able to completely excise the disease, which is eating into those sciatic, sacral nerve roots. And another case that we did with Raj, a lady who needed a nephrectomy because of endometriosis. So for some of my colleagues who used to call this a lifestyle disease, this is a young lady, 25-year-old, I think, from another European country, who has lost her kidney to endometriosis, because when you get obstruction of the ureter and it's missed, then you're going to lose that kidney. So we did a three-way operation with the colorectal and the urology team to completely excise the endometriosis, do a nodulectomy on the sigmoid, and also remove the kidney, which we published. Now, more relevant to the topic of tonight, I'm going to just go through 3 cases of thoracic endometriosis. Let me just pause this first. So the typical patient that you may get involved in as first line is somebody who's come with a pneumothorax, catamenial pneumothorax, catamenial hemothorax. Normally, the chest pains don't get referred to you first. They may do. And it's quite difficult to diagnose because only around 5% of patients with endometriosis have thoracic endometriosis. And out of those, only around 20% of them will show on MRI. So, the decision-making becomes quite difficult in the absence of a positive imaging. So this lady was 35, known to have endometriosis. MRI had shown a rectal nodule, but nothing on the diaphragm. So this is, but the patient was symptomatic. So we had spoken to her about excising the disease from the diaphragm. The first case is an example of when endometriosis of the diaphragm is superficial. So you can shave it off. So this is endometriosis, and we are not entering the chest cavity. We're just cutting around it. Quite simple procedure. The access could be a bit challenging, and getting below the liver could also be another challenge. But we mobilize the liver. We we use a 30-degree scope, go behind the liver, and try and excise all of the endometriotic lesions that we may see. But this is simple. We're not necessarily going to need the thoracic team for that. But in around 20% of these cases, the disease goes a little bit further than that. So this lady, quite young, 24 years old, but we already knew that she had a deep endometriotic nodule. MRI had confirmed that for us. So this was a joint case with Andrea. And what we always do, we start from the abdominal side, we mobilize the liver, we excise whatever we can from the underside of the diaphragm, do a peritonectomy if necessary, and then demarcate the areas of endometriosis that are deeper. We try and leave the opening of the chest cavity for the last step so that we have good access and the lung is still being ventilated. So you will see that the Morrison's pouch and the posterior aspect of the diaphragm is very commonly involved. And if I go back a little bit, you'll see that until I mobilized the liver and pulled it aside, I wasn't even seeing that very deep nodule over there. So we do as much as we can abdominally, and then open the diaphragm. At that point, the anesthetist will deflate the chest, and then we continue, and then we go to the VATS part, which I'm sure Andrea is going to touch on. So the point I want to make in these is that now in our series, we have seen it at least 4 or 5 times, that when we thought that we had completely excised the endometriosis from the underside of the diaphragm, when we went and did the VATS, we could see more disease on the abdominal side, and you'll see it in a second. So now we're in the chest, and Andrea is removing the disease from the pleura. And then when we look through the opening of the diaphragm into the abdominal cavity, you will see in a second that we'll see more disease. So had we not done the VATS at the same time, we would have missed that disease. And that would have been very embarrassing, for a patient undergoing such a big operation and then us leaving disease behind, which, as we've demonstrated a few times now, very, very easy to do. We've published this in April, I believe, April this year, in the American Journal. So you can see what the disease looks like. You see brown, thickened areas inside the muscle. Sometimes you see chocolate material, brown material coming out of it. And I think it's really important here. Here you see that this is the disease that we would have been leaving behind had we not done the VATS. And then we're doing this together. So I'm drawing on the screen while Andrea is going through the diaphragmatic opening into the abdominal cavity, excising the areas that are left from my part of the operation. And then the rest, I'm sure well, I don't need to tell you how the diaphragm is closed. I'm actually amazed by how nice your operations are. Then the third case. So yeah, okay, Andrea's closing, so I'll leave it for him to explain the technical aspects of that. That is way above my pay grade. So this is the end result. Peritoneum closed. Usually the clinical outcome is great. So the pain will go away once they've recovered from the surgery, and whatever pain they have, I usually blame it on you. I say, I don't know, talk to Mr. Bille about your pain. Last patient, 44 years old, again, another full thickness endometriotic nodule, and we could see fenestrations. This is another picture that you will see in the diaphragm. I still haven't understood how this happens. and I hope you can educate me that why do we see these fenestrations, whether or not it's ischemic, why would endometriosis cause fenestrations? But generally speaking, we really don't understand endometriosis, and the answer to most questions about endometriosis is we don't know. We don't even know the pathophysiology of endometriosis properly, apart from knowing that it's a combination, likely a combination of multiple factors working together to cause the problem. And you can see the adhesions that the endometriosis had caused. And Andrea is now doing what do you call it? Excising the apex of one of the lobes. And the last one, I will have another 2 minutes, is a lady who we did three of us together. So me and Andrea and Raj. The disease was in the Morrison's pouch, just under the liver, very clear on MRI. And she already had a thoracotomy, and mesh was placed on the diaphragm, actually without completely removing the disease, which again is something that I hope Andrea will talk about, that the problems that we have in patients who've had pleurodesis, and how that causes problems for us when we need to then go and excise the disease. So here is Raj working around the kidney. This is the right kidney, and the disease is basically overlying the right kidney that needs to be excised from this area. It's involved part of the liver as well, and slowly work our way through the plane, if you can call it plane, and we excise all the abnormalities that we see. And you saw that brown material coming out of the disease, which was what was making it more visible on the MRI. So we remove that capsule. You see that's the capsule, like a endometrioma, a chocolate material that was within that capsule that we remove, and then we pack with some tonsil swabs. And then we turn to the rest of the diaphragm. In this case, we decided not to do a thoracotomy and see how much we can win. And in fact, the patient got a lot better. Okay, that's me. Thank you very much for listening.
Thank you very much, Shaheen. That was an excellent summary, and really nice to see some really interesting videos, which are sure are going to be food for a lot of thought towards the end of the webinar. So we'll save discussion and questions to the end, and I'll pass on to Raj Nair, who's going to talk about the urology side of things.
Thank you very much. Let me just get my slides up. I'm sure you can, just to check, you can hear and see me? Great. So, yeah, no, and again, a real honor for me also to present. I mean, I was thinking of a title for this, and to be honest, it's just bizarre. Lessons from a urologist pretending to understand gynecology and speaking to thoracic surgeons. I mean, you can't make it up. So I will try and enlighten you with my knowledge of a topic that is not my specialist field, to a group of surgeons who operate as far away from my part of the body as possible that I deal with. But nevertheless, the fact is we're all in it together. And as Shaheen has mentioned, it's multidisciplinary surgery when it comes to complex endometriosis. And so you do have to be a jack of all trades in urology when you're managing endometriosis, mainly because it can affect any part of the urinary tract, the lower urinary tract, the upper urinary tract, and anywhere in between. And for that, you do need to have various skills in managing this. And what I have learned through the practice that Shaheen and the team have all developed is that it's an interesting one when you look at imaging, because imaging doesn't necessarily give you the complete picture, particularly from the urological side. Often dissection planes are much harder than you think. The disease is much more advanced than you think. And you go in with plan A and end up having to do plan B or C based on what the intraoperative findings are. So it's almost trying to look through a crystal ball that's not really giving you the answer. But as urologist, the majority of work, or the majority of the reason why I'm there, is to stop a ureteric injury, or at least try and repair a ureteric injury when it happens. And I'm hoping that I can just give you a flavor of what urologists do in this multidisciplinary practice. You, for all those who do deal with thoracic endometriosis, where there is multiple teams involved, you'll probably start to understand why certain things, why we do certain things that we do prior to your bit of the operation. But most urological injuries that do occur from gynecological surgery, it's no reflection of the quality of surgery, it's just a reflection of the anatomy and the disease most of the time. I have had to deal with a thoracic ureteric injury. And that's N equals 1, and that was for a ureter that was cut where the kidney had actually migrated up into the chest from a diaphragmatic hernia. So that in the attempt of trying to pull the kidney back down into the abdomen, the ureter was injured. So that's my claim to fame there. But in gynecological reasons or pelvic surgery, why does the ureter get injured? It's because it sits right underneath the right uterine artery, and that's where most endometriosis is concentrated. And the endometriosis itself wraps around vessels and the ureter like an onion, like almost like layers of an onion. And so you almost have to unwrap that and really just release the ureter here, as you can see in the middle picture. In addition, of course, what we do as surgeons is very important around the ureter. Thermal injury is not to be missed. And so what often what do we often do, particularly with the pelvic endometriosis cases, is with the complex ones, is to stent the ureters. And it just doesn't necessarily reduce the chance of ureteric injury, but it does allow us to identify the ureter a little bit easier. And there are various other things that you can do. You know, some of the stents have got illuminated light. Some of them you can also put in indocyanine green if you're doing a robotic ureterolysis. And that allows you to identify where the ureter is, particularly useful in the very thick fibrotic peritoneal reactions that might occur. But it doesn't necessarily prevent injuries. And here's just examples of I know I've cut out the bit of the body where you guys are interested in, but this is the abdomen. And in the pelvis here, you can see there's contrast that's leaking from the right ureter into the pelvic cavity. And that's from a distal ureteric injury where the urine is leaking out from the back of the bladder there. And in this case, a few days after a robotic ureterolysis, or a laparoscopic ureterolysis actually, here we have an obstructed right kidney, and whereas on the left kidney you can see contrast draining down the ureter. And the reason for that is actually on telescopic examination on ureteroscopy, you see a full thickness circumferential burn of the ureter, and that's simply due to diathermy effect. So being really careful around the ureter is critical in terms of preventing that thermal spread. The techniques have evolved. One of the nice things is that actually when you work with teams that are all familiar with a particular technique, whether it be all open surgeons, all laparoscopic surgeons, or robotic surgeons, it means that you can use that technology together. It's one of the nice things of working, again, in a multidisciplinary team where we have access to robotics, is that we tend to do most of our surgery this way now. And it means that we can all just jump on the machine and or toggle between the consoles in order to try and achieve the same, try and see the same result for the patient, rather than opening and reimplanting a ureter if one wasn't laparoscopically proficient. So just a few very quick videos just to show you some of the steps of surgery. And this is basically just trying to show you what a ureterolysis is. This is us looking down into the pelvis. The thing that's being held on the left-hand side there is the ureter. Here you go. It's like a dilated ureter. And what we're trying to do is dissect the ureter with some of the peritoneum on it, higher up, in order to try and preserve the blood supply. As you get closer to the pelvis, what you want to try and do is skeletonize the ureter in a way that you don't get too close to it, so that you destroy its blood supply, but at the same time you don't want to leave endometriosis on it if it's there. And so it's a fine balance actually, and you can see sometimes it's nicer often to leave some tissue on the ureter in order to preserve that. When we're reconstructing, it's a challenge, because you think you might be going in to do one thing, but you actually often have a number of other, you may actually need to employ a number of other strategies, and particularly the endometriosis that keeps creeping up higher and higher and higher on the ureter, towards the kidney, towards the renal pelvis. Those are the ones which are particularly difficult because the reconstructive options are much harder the higher up you go outside of the pelvis. So we've got, for urologists, we've got our little mantras here. If most disease is within the distal ureter, we can just detach the ureter off the bladder, or detach the ureter from the endometriosis and just simply plumb it straight back on. Sometimes we have to hitch the bladder up in order to get the distance right, to get the tension off the ureter. Sometimes we have to cut a flap off the bladder, and that's called a Bouari flap. And in certain circumstances, in the mid-ureter mainly, we can just join the two ends of the ureter together. But as you go higher, you need to think of more novel ways of trying to get the ureter back onto the bladder in some way or form. And that's often the kind of disease where you may be involved with a thoracic surgeon dealing with disease up in the diaphragm as well. And I think actually it's quite important when we're dealing with anastomoses to really think about what the other the other third or the other quarter of surgeons are doing. Often we have this dilemma with our colorectal surgeons. If they're going to do an anastomosis, we really want to try and avoid an anastomosis because anastomoses tend, if you're lucky, or not lucky if you're skilled, they stay away from each other and you don't get fistulae that formed. But sometimes you can, so you want to try and avoid that as much as possible. And the same applies for any work in the chest and any work in the urinary tract or bowel, particularly if you're using mesh. Really want to try and minimize any chance of urine spill or bowel leak that might result in infection. So ureter or ureterostomies are basically joining the ends of the ureter together, and we can do that in the middle or the upper, mainly in the middle ureter, because the blood supply comes from both the renal artery cranially and inferiorly from the internal iliac artery, and going up as a marginal blood supply. Psoas hitches is just whereby few stitches are placed on the bladder, allowing the ureter allowing the tension of the bladder to be taken off, so that the ureteric reimplant isn't under tension, so you don't pull on those very fragile blood vessels that the ureter has, and you apply usually 3 or 4 sutures just to keep that bladder right up against the psoas tendon and avoiding the genitofemoral nerve. And ureteric reimplantations are basically just, here you can see, that's the bladder that I'm cutting into there, just to orientate yourself. This is the mucosa of the bladder, that blue, that's just the sort of saline that we put in. And then you just make a little cut into that. Decompress the bladder, and the idea is you can see the ureter being held by the fourth arm robotically there. And what we're trying to do is just simply rejoin that to the bladder over a stent. And most of these have to be stented. Here's the stent going in. So a posterior wall is performed, a posterior anastomosis is performed. The stent is pushed up towards the kidney. The wire is taken out, and the stent is plumbed into the bladder, pushed into the bladder like this. And then we just complete the anastomosis. Some of these patients get a bit of reflux, so when they start voiding, when they start peeing, some of the urine goes up towards their chest, towards their kidney, sorry. And so you could, us as urologists need to warn them about it. There you go, just completing that anastomosis there. And then you've got flaps that we take off the bladder. So this is just dissecting the ureter down, but what I really wanted to do is just move this along. And you can see here, this is the bladder that's dropped down. We're just measuring a flap that we can take off the bladder. Like this, and that's the bladder you can see there, and you'll just see the catheter balloon on the inside in a second. And this is spatulating the ureter to get as much distance as you can, removing any diseased ureter, and then joining that flap onto the bladder so you can recreate a tube. I'll just move the video along just to show you that. Here you go. You're just reconstructing the bladder back onto the ureter. So there's sometimes these procedures are very quick, and sometimes it takes time. It's the reconstructive bit that you cannot get wrong, because that's where most of the complications lie. Often excisional surgery is a lot easier in terms of avoiding complications, but it's the reconstruction that can lead to them and result in much more in the way of problems. So this is what's called a cystogram, where we inject some dye into the bladder, and you can see the bladder's pulled up to one side, and that's the final appearance of a Boari flap. And then there are weird things that we do. Sometimes we can get a bit of appendix. We can plug one end to the ureter, one end to the bladder. Sometimes we take a loop of ileum and we can shove one bit all the way up to the renal pelvis, particularly for those, wide, long length strictures, which we very rarely see with endometriosis. I have seen it once, and then you can basically reconstruct a ureter using a segmental bowel. And this is some cool stuff that we do now. This is actually a patient who had endometriosis with the resultant stricture that it formed. This is actually, probably about a year or so after her endometriosis surgery. You often let the strictures mature. You've stabilized them with a nephrostomy or a stent. And then you can see that's some stricture site there. But what we do is we spatulate the stricture and harvest some graft from the inside of the mouth, so some buccal mucosa. And you can almost place it right on top like an augmentation and augment the ureter so it's much wider. And this is here, you can just see there's a bit of graft. That's from the oral mucosa. And we just take that out and put it through one of the robotic ports and anchor it in. I have no idea how this works and how it picks up a blood supply or how it manages to not just necrose and fall apart, but it doesn't. And it's quite incredible. So this is just showing you the graft is being anchored in. And then you can just suture it on. And again, everything is over a stent. So, and this patient also had some diaphragmatic endometriosis. So this was ureteric endometriosis high up against the renal pelvis, which was excised at the original operation. So then results in a stricture forming because of a devoid blood supply, and this is us sorting out the stricture afterwards. And of course, there's often taking part, chunks of bladder out, because often the bladder is involved. Well, we do often see bladder endometriosis, and usually at the level of the ureter joining the bladder, but sometimes we can see it at the dome or other areas. And we have to do a partial cystectomy and close the bladder and leak test it. We use ICG a lot. I know Shaheen also uses ICG, and it really is just quite a nice way of looking at the vascularity of the ureter, vascularity of the bladder, vascularity of anastomoses. But we also use it for identification as well. And I think some of the things that have been the most useful thing for me is when, we often presume this is a disease that is managed by a specialty, the gynecologist, and that's it. And they should only see the gynecologist, and we rock up to theatre and deal with these patients. But the reality is they come with a lot of baggage. As Shaheen has mentioned, it takes, the average time to diagnosis is 8 years. They come to you in desperation with chronic pain, difficulty in getting pregnant, multiple cycles of IVF that have failed, at a lot of anguish. And meeting those patients beforehand and talking them through your part of the operation, even though, it may be that someone else may not have mentioned a particular side effect or a complication, is incredibly valuable, because they need to understand that this is a team. They've often had single surgeons operating on them, and then they've resulted in recurrent endometriosis, and then they come to you thinking, why hasn't it been sorted the first time? And I think the team-based approach is incredibly important to showing patients that they're being looked after by a group of people, but also managing complications by experts is equally important. So it is an important thing. And so, as I say, use your colleagues and build the right team. From my side, the only predictable thing is how unpredictable everything is, and so thinking on your feet is important. And complications do happen, and this is just showing how ureter. This is just a cystogram showing a leak from the bladder after a reimplantation. And when that happens, you intensify your interaction with the patients and ensure that they feel that they're looked after. Because, as I say, the journey to get to that point is often a very lonely one for them. So thank you very much. I hope that's been insightful from my side. And I'm looking forward to hearing the next talk.
Thanks very much, Raj. That was really interesting and really nice to see what you're doing from your side and some really elegant reconstructive surgery. So I think actually it's very useful from the thoracic perspective for us to understand how different specialties do their reconstructions, and it all translates into what we do, as well as the multidisciplinary management of your patients. So really, really interesting. Thank you very much. I will hand over now to Dr. Bille to talk about the thoracic surgery behind it, and show us some thoracic surgical videos as well.
Thank you very much, and thank you very much for inviting me to be part of the of this interesting webinar on endometriosis. So we're going to discuss now more in specific about thoracic endometriosis, and I hope you can see my screen now.
We've got black screen. Oh, there we go. Yep, got it now.
So in terms of thoracic endometriosis, we know that, thoracic endometriosis, as Shaheen was saying, is rare and is more frequent in patients that have quite advanced and deep pelvic endometriosis. And outside the abdominal pelvic cavity, the diaphragm is probably the most frequent locations of the endometriosis. The diagnosis is often delayed. Mainly in patients, they only have chest pain, because most of the time, even by their GP, the pain is disregarded. Of course, most of the time, those patients, they go to A&E, but because they don't present any instability from a cardiovascular point of view, they don't get extensive tests, but also, it's quite a high demand to start and CT scan all of these patients, also because they're very young and you want to avoid to expose them to quite a high dose of radiation. Of course, the true prevalence of thoracic endometriosis is not well known, it's rare anyway. And in our practice, in the thoracic practice, we have some obvious presentations like the catamenial pneumothorax. Of course, when you have a female, you always have to try to link or correlate the pneumothorax to their menstrual cycle. The hemothorax, rarely you can see hemoptysis, and sometimes you can see like pulmonary nodule as a presentation of endometriosis. But a lot of patients, they don't have any pneumothorax or hemothorax, but they only have some chest pain, dyspnea, and cough. And of course, you try to investigate those symptoms from a functional point of view. You can perform a lung function test. And what is really important is, of course, the radiology test. This is a patient of mine who had chest pain quite a few times. And in these situations, you can see how the chest X-ray is barely normal. But then we decided to upgrade to a CT scan. And you can see how sometimes those patients have a very, very small pneumothorax that can be missed, maybe in a general setting in A&E, but could be the cause of their symptoms. A lot of our patients, of course, they got the MRI. And as Mr. Khazali was saying, in about 80%, the MRI may be entirely negative. So what do you do? Sometimes we are driven by the symptoms in order if we have to offer surgery or not. In a case like that, you can clearly see there's an obvious defects on the MRI. And what you see here is the liver herniating through the defect. But sometimes you have an MRI like that, which is entirely normal, is reported as normal, but patient have symptoms. And then you go and you operate on those patients, and this is what you find. You find multiple fenestration. So one of the difference is that sometimes when you have deep nodule of endometriosis, then you can have an uptake on the MRI, but the simple fenestrations, because they are very, very tiny hole in the diaphragm, can be missed either on MRI and CT. Of course, nowadays, the minimal invasive surgery is considered the gold standard for diagnosing and treating thoracic endometriosis, and has been advocate the use of a collaborative approach at the beginning, about 20 years ago, with VATS and laparoscopy. But nowadays, robotic, I think, helps to facilitate a collaborative approach and be able to reach different areas within the chest and the abdomen. Of course, many of you knows that the advantages of the robotic surgery compared to VATS for us, which is the 3D high definition view, the depth perceptions, and also the wrist motion of the instruments, which allows us to be able to look at and work in different compartments and quadrants of the chest cavity. What are the clinical advantages of robotic surgery? Well, definitely you will see a shorter length of stay, less blood loss, shorter recovery even after discharge, and less neuropathic pain compared to VATS. This is the standard VATS approach I was using when I was doing pneumothorax, usually 2 or 3 ports. Sometimes the camera was switched from the camera port to the utility when we had to work on the diaphragm. But sometimes it was difficult accessing and suturing all the different area of the diaphragm. Then when we moved to robotic, the robotic approach, we normally use an X-size system coming from the side, and we target the robot with a pelvic approach focusing on the diaphragm. The advantage of this is that because the robotic system is extremely flexible, you can rotate the bone and also with the same port perform a thoracic approach and pelvic approach without having to change the position of your port. This is the typical position of the port. I put my port slightly higher. One is the camera port is close to the scapula. Then you have 2 further 8 millimeter ports and an assistant port that, of course, you need to have the needle or the mesh position. How we treat the endometriosis? Of course, we can do minimal invasive. For me, now I switch completely to do those cases robotically because I think that, again, you can achieve the same results when you do VATS versus robotic, but it's like flying. If you can fly business, would you really fly economy if you can make your life easier to access the different part of the chest? And of course, if you see pleural lesion, normally I think that a pleurectomy should be performed. Sometimes you can see visceral pleural lesion or possible bullas that could be related to endometriotic spot. In that case, as we do for the pneumothorax, we do a wedge resection of that area. For the diaphragm, I think if it's a superficial, the best approach is the shaving. Of course, if it is a full thickness endometriosis, we should excise the endometriosis and repair the fenestration. I try not to use the talcum powder, and I only use the talcum powder for recurrent pneumothorax because the talcum powder can cause inflammations, quite a lot of pain. And remember, a lot of those patients, they come to you for the pain. And you want to minimize the postoperative chronic pain that could even be related to the talcum powder. And also, if you have to go back because endometriosis can come back, having the talcum powder in the chest can make the redo surgery extremely complex. The other big question that we have to ask is that, shall we always need to use a mesh? I think not. So I think that, if you can excise and repair the diaphragm directly is better. In case of a catamenial pneumothorax or a large defect, probably is better to put a mesh. And I do believe that a biological mesh is better than synthetic. One, to prevent the possible risk of infection of the pleural cavity, but second, because I had a couple of situations when I had to remove Gore-Tex mesh for, again, chronic pain, probably related by this foreign material. So in my experience, what I've noticed that so far, I didn't have any conversion using robotic. I didn't have any inpatient postoperative complications such infection, bleeding, or prolonged air leak. The median length of stay was less than 2 days. Most of the cases, in about 80%, there was still active endometriosis, but in about 20%, we only found fibrosis. So if this was all the endometriosis and with the residual fibrosis, or was just like a pleural inflamed due to a previous pleurisy, it's hard to say. In our experience, we only have one patient said to go back and require talc pleurodesis. A lot of them, even with the catamenial pneumothorax, didn't have any recurrence. So for me, it's important that we try to, as a thoracic surgeon, try to understand that the thoracic endometriosis is probably underdiagnosed. we have to work together in a multidisciplinary team. I always want to work with a gynecologist because, even in the chest, having a second pair of eyes is very helpful with an experienced gynecologist to try to excise whatever looks abnormal. A combined approach is probably the best in order to try to minimize any possible trauma on the diaphragm. And robotic surgery, I think, really improves the outcome. I'll briefly show you a quick video, and then we can go to question. Let me just now share the video with you. I think you should see the video now. So here you can see again some fenestrations in the diaphragm, and you can see some brown spot coming out. Of course, normally I'll do the excision with the spatula and the bipolar. You can use the vessel sealant or the synchro seal to cut the diaphragm. Of course, I'll try to minimize the area of the diaphragm that I have to excise. Most of the time is the central tendon, the area which is affected by the endometriosis. And then we proceed with the reconstruction. Normally, I like to reconstruct using the Etibond #1, which is a non-dissolvable suture. And then I reinforce the area with a Stratafix or a V-lock, having like a kind of like double layers. Doing that, we didn't have any issues in terms of like possible hernia of the bowel content or any raised diaphragm. And as I said, I'll try, of course, not to use any mesh. And as you can see here, I put a few interrupted stitches in order to completely close the defect. And when the defect is closed, at that point, I normally position a V-lock or Stratafix on top. Here you can see I'm continuing to close all the diaphragmatic defect. And I do like single suture. In this case, because it was a catamenial pneumothorax, and I was worried about recurrence because she had several pneumothorax before she came to me, and there was no adhesions at all. Sometimes for the catamenial, not for patient, they presented only with pain and endo, but if they have fenestration, because I'm worried they may develop more fenestration, I usually put a mesh. The mesh that I normally use is a biological mesh. In this case, was a Surgiment that now is not available anymore. Now I use the Ovitex. And again, I normally fix the mesh with some interrupted, non-dissolvable suture. And then again, I do a running suture with the V-lock that you can see here. Of course, the urologists are and gynecologists talented and skilled stitching because we use in many cases staplers rather than suturing. And this is the running suture, sorry, and the final results of the mesh positions. As Mr. Khazali showed, sometimes we have to wedge the lung. We always check the lung to make sure there's no any deposit. As you can see here, we do a careful inspection of all the diaphragm and to make sure there's no like any fenestrations or any lethal hole. In this case, there was like a fibrotic area at the top. Either could represent an endometriosis, but most likely a bulla. Sometimes you can find endometriosis on the diaphragm, but also emphysematous changing of bullas into the lung. In this case, as Shaheen showed, we proceed with a wedge resection or bullectomy of the area involved. And of course, then we remove this. This is another example of fenestration that you can see. And I just want briefly before we finish, because you can see how you can explore it, and Shaheen show it to you, also the diaphragm from below. And then some area, mainly the one behind the liver, that is sometimes it's easier when you open the diaphragm to assess them from above. And you also have to not mobilize too much the liver, potentially avoiding complication. And sometimes if there's any concern regarding the liver, we may involve the liver surgeon as well in cases more complicated than standard mobilizations of the liver. Again, here is another example of reconstruction and repair. In this specific case, I use a Gore-Tex mesh, and you may ask you why you're using a Gore-Tex mesh. Then this was a patient, it was like a vegan patient, was absolutely against using any biological material derived from animals, so I had to use a Gore-Tex mesh. But these patients had a more complicated post-op because she has a tiny reactive effusion, which I didn't see or experience with the biological mesh, and she had more pain, and the pain took longer to settle compared to the biological mesh. And again, I fixed the synthetic mesh the same way I fixed the biological mesh, as you can see here. And this, to conclude, is an example how you can do a full pleurectomy with the robot, just turning the boom of 180 degrees, and precisely you can really excise all the pleura to prevent a pneumothorax. So if I have a patient with a catamenial pneumothorax, I usually assess the diaphragm, excise the fenestration. Sometimes I'll put a mesh, and then I prefer doing a pleurectomy rather than using talcum powder, because I think that the talcum powder sometimes cause more pain. In case there's as I said, there's a recurrence of the endometriosis, it may be extremely difficult to reaccess the chest, and the chances that you have to do a thoracotomy rather than a redo robotic is higher. Thank you so much for your attention.
Thank you very much, Andrea. Really nice to see the thoracic approach, and also to see some of the videos of the different aspects of thoracic surgery and endometriosis. We've got a few questions. So I'll start with the ones that are coming through on the Q&A, and then a couple of things that have kind of come to mind as well. So the first question is with regards to the timing of surgery, and whether or not you specifically would aim for any pre-hormonal treatment, or whether you time your surgery in relation to the patient's menstrual cycle. Maybe that's a question for Dr. Khazali.
Yeah, thanks for the question. Not really. One, it really is not practical, and two, we haven't really seen a huge difference. So endometriosis of the diaphragm will not go away when you're in a particular time of your cycle. You will always see it. And a lot of these patients are already on hormonal treatments anyway, and many of them don't have a period. So no, we don't aim to time it with any time of period. Oh, you're on mute. Sorry, Leanne, you're on mute.
Sorry about that. Yeah, we've got another question in the chat that maybe follows on from that, in that there's a comment that many specialists compare endometriosis to metastatic disease. And if so, it seems a bit crude as a surgeon cutting out areas of disease. And how does that control systemic spread by just cutting out a selection of lesions? How can you be sure that these lesions don't recur as soon as you've taken them out?
Yes. So no, it is not like metastatic disease. So this has been an unhelpful comment from maybe some of my colleagues. First of all, we don't really understand the pathophysiology of endometriosis, but the more likely explanations are a combination of genetic and embryological implantation of tissue in areas that it shouldn't be. So it doesn't work like endometriosis then spreads to other area if you from a central place. And we know that from two places. One is that 102 years ago, a guy called Sampson came up with a theory that was at the time, and still, the simplest explanation, that was retrograde menstruation, and then you get implantation of the endometrioid tissue in various areas. And that does to some extent explain endometriosis on the diaphragm, for example, that if you have implants, then you may get that. But that has never been proven. And it does not explain endometriosis in areas that are completely away from the abdominal cavity. So we don't think that's a sufficient explanation. There are case reports of endometriosis being in areas like brain, for example. Very, very, very few. I've never seen it. And those may be spread in that way, but almost all endometriosis, we think, have been there before. And in fact, some studies looking at children who died from sudden infant death have shown that up to 10% of these children, female, have endometriosis on histology. So yes, the notion of metastases is incorrect.
Thank you. That's really interesting. There's a few other questions, maybe one more for you in terms of recurrence of thoracic endometriosis. Perhaps, Andrea, you want to take that?
Yes, there are not many data. I think that the main difference is between excising and ablating the endometriosis. So if you ablate the endometriosis on the diaphragm, I think the recurrence is quite high, but I wouldn't really talk about recurrence, that you probably already leave endometriosis behind. If you achieve a full resection, I think that the risk of recurrence is probably less than 10%, around 1 in 10. So you need to be careful. And I think I always be very reluctant to go back too soon, because sometimes with thoracic surgery, you may have neuropathic pain. And for the first few months, it's very difficult to distinguish between endometriotic pain and neuropathic pain after thoracic. So I'll usually wait 6 months even before thinking of rescanning and looking at the patients for like any possible recurrence.
And if I may add to it,
Yeah,
is, if I take you back to 2 of the cases that I showed, even when we thought that we have achieved complete excision abdominally, when we went thoracically, we could see more disease. And I suspect that many of those reported recurrences are, as Andrea said, incomplete excisions or ablations. Ablation, we have this problem in the pelvic endometriosis. Ablation of endometriosis does not achieve anything. Endometriosis is much deeper than what we can see, and diatherming the surface of it does nothing. And then when we look at those patients and say what percentage of them recurred, I agree with Andrea that this is not the right term to use. It hasn't recurred. It wasn't treated in the first place.
Thank you. It kind of leads on a little bit to a question about the choice of imaging. That's something that I was going to highlight, is that we often see patients in our thoracic surgical clinics with a history of endometriosis who come in, who've also presented with pneumothorax. Now, a lot of these patients smoke anyway, particularly from some of our catchment areas. And there is a difficulty in determining whether this patient who presents to you in clinic, who smoked, got a 20-pack-year smoking history, is in their mid to late 30s, has a history of chronic pain and endometriosis, can't remember whether or not their pneumothoraces are related to their menstrual cycle, or if there's any kind of correlation, is already taking a large number of neuropathic pain medications. And you're presented with somebody who's had recurrent pneumothorax, and they come to a thoracic surgical clinic. What would be your sort of team approach to that patient, and how would you image them? Because those patients come to us with a number of chest x-rays from A&E and a CT scan that shows some apical Bille. Now, that might be the end of the story, and that might be it. But the approach that we might have surgically would be different depending on what the underlying etiology is. So how would you, as a multidisciplinary team, investigate and subsequently manage that patient?
Shall I take this part? So Andrea will tell you that we spend maybe 80% of our effort and time and energy on trying to convince patients not to have surgery. Endometriosis of the diaphragm is real. It is underdiagnosed, but we really need to leave surgery as the last resort when we have gotten closest possible to the diagnosis. So the way we approach this is, first of all, the histories, like every other areas of medicine, the most important part. You can get irritation of the chest from retrograde menstruation, and this can sometimes confuse some of the patients. In fact, just a couple of weeks ago, I posted a video on my YouTube channel trying to explain that not all cyclical chest pain is a diaphragmatic endometriosis, and I had an angry comment saying that I'm dismissing their symptoms, etc. So this is the first thing to notice, that trying to spend time with the patients explaining that the symptoms can come from various different places, and diaphragmatic endometriosis is only one of them. The second thing is most diaphragmatic endometriosis would have pelvic endometriosis, first of all, and most of those would also have an evidence of endometriosis on the underside of the diaphragm. And correct me if I'm wrong, although Andrea does correct me from time to time when I say this, that a laparoscopy probably is a less painful procedure than a thoracoscopy. And therefore, maybe offering them a laparoscopy and having a good look under the diaphragm would be a good step, because if that doesn't show endometriosis on the diaphragm or endometriosis in the pelvis, then it's very unlikely that they only have endometriosis on the chest side of the diaphragm.
Very briefly, I agree with Shaheen. I think also to assess the diaphragm, the MRI and who reports the MRI is crucial for that. I think that, a good laparoscopy, a good view laparoscopically to the diaphragm is even better than all the tests we can do. Sometimes I will add a CT scan if I'm concerned about severe bullous disease or any lung nodules that I want to characterize better. But in many cases, we just do the MRI, but we mainly rely on the clinical presentations and on the laparoscopic findings, because of course laparoscopy, I agree, is less painful than a robotic or thoracoscopy approach.
So would you say an MRI of the sort of diaphragmatic areas your imaging of choice for diagnosis outside of a direct visualization? Is everyone in agreement with that?
Yeah.
And is that a similar approach within the abdomen? Is MRI your choice imaging?
That's right.
Excellent. We've got a couple of questions before we're going to have to wrap up. So just moving on, I think we've already covered the question. If this one to Andrea, if you discover fenestrations during an operation for a right-sided pneumothorax, what do you do? Would you just directly close those? Would you resect anything? Would you talc that patient?
I normally excise those fenestration, because just to prevent the pneumothorax probably is enough to directly repair it. But if you have any associated small deposit of endometriosis, you may solve the pneumothorax but not solving the pain. So normally I'll excise and directly repair it. And I only now use the talc for a recurrent pneumothorax. After the first surgery, if they come back with a pneumothorax, then I'll talc them. But I try not to talc a patient during the first operation.
And that's the same if you had a patient who didn't have a known diagnosis of endometriosis at the time, and it was only found clinically. Excellent. There is a question here about stapling the diaphragm. From personal experience, that's a bad plan, but would you like to add anything on that?
Personally, I don't like to staple the diaphragm. I think sometimes there's too much tension on it. Sometimes you can have a rupture of the staple line. Even based on my experience, I found it absolutely fine to stitch it. What I can say that probably I was more tempted to stapling the diaphragm when I was doing VATS, because it was difficult stitching. But nowadays with the robot, it's so much more comfortable stitching that I don't really see the need to staple the diaphragm.
Yeah, I think I agree with you. And from a thoracic perspective, adding the risk of tension, rupture, diaphragmatic herniation, potentially tearing abdominal structures, I think where you can suture something, you're in a better situation. The question to all of you in terms of the timing of and duration of follow-up. As a multidisciplinary team, how long do you follow these patients up? And perhaps we can take an approach from each one of you to wrap things up.
So, okay, I'll start. So the BSGE requires us to follow these patients up for 2 years. So we see them at 6 months, 12 months, and 24 months. In fact, we don't see them, but we send them a questionnaire at 6, 12, and 24 months.
Yeah, from my point of view, for the urological endometriosis, so if it's just a urethrolysis and a stent, usually we take the stent out immediately after the operation or a couple of weeks after the operation, depending on how extensive the urethrolysis was. And I tend to do an ultrasound scan of their kidneys to make sure they haven't developed a delayed stricture between 6 weeks or 8 weeks afterwards, and then discharge them. If they've had reconstruction, usually a stent comes out after about 6 weeks once the anastomosis is healed, and then they get some sort of functional imaging or CT scan to look at the drainage of the kidney after that, and then a scan at 1 year, because 5% of patients can get a delayed stricture forming. So worth just knowing that, and then I discharge everyone.
Usually I follow them up with 2 appointments up to 6 months, 3 and 6 months, apart from the first consultation after 2 or 3 weeks, just to make sure that the pain is settling, is getting better. And then normally I leave Shaheen, follow them up for 2 years, and only refer them back in case there's a significant worsening of the chest symptoms.
Excellent. Fantastic. I think that probably brings us to the end of the webinar. I'm just very grateful to all of you for taking the time to come and talk to us all today. I know there are still some questions coming in, and apologies if we haven't managed to answer those directly. We will be posting the webinar on CTSNet, and if anyone's got any comments, you're very welcome to add some comments onto the posting, and we can always try and answer things there if needed. So thank you very much for everyone for attending. Thank you very much to our panelists for taking the time to talk to everyone today. And thank you for CTSNet for hosting us.
Thank you very much.
Thank you. Thanks for having us.
Bye.
Thank you for attending the CTSNet original webinar. As a reminder, a recording of today's webinar will be available early next week on ctsnet.org and CTSNet's YouTube channel. Please look forward to 2 premiering guest editor series and their accompanying webinars taking place exclusively on CTSNet over the next month. The first series, led by Dr. M.M. Yusuf of Apollo Hospitals in Chennai, India, will focus on robotic-assisted coronary artery bypass graft surgery, techniques and procedures. The contributor videos will start the week of August 5th. Have a wonderful rest of your day.